we're going to welcome our first surgeon to the stage. So we are very, very lucky to have Piyush Mahapatra here, who is a consultant in trauma and orthopaedic surgery at West Hertfordshire Hospital. And he's here to talk to us today about sustainable models of care. Thanks, Piyush.
Thank you very much. Yeah, it's scary being on this side of the blood-brain barrier. So I'm going to talk to you today about sustainable models of care. And just by way of sort of disclosures, as mentioned, I am a practicing clinician in the NHS. I do have some innovation roles both locally and nationally as part of the NHS Innovation Accelerator. And the most pertinent for this is I'm Chief Innovation Officer at Open Medical. We do cloud solutions, so some of the case studies will be from that. But again, the one thing I did want to stress is I think industry does have a role to play, particularly in collaboration. So we work quite closely with the ABHI, and I think that's something that as an organisation, the NHS needs to probably be better at to try and address net zero. So, in terms of things to think about, now, clearly there's been a lot of fantastic work being put into the net zero agenda. A lot of that has been around estates and facilities, and those have been fantastic. I think with the only problem with models of care, that work is often lagged behind. We have to acknowledge that the current operating environment in the NHS is extremely challenged. I think this is not news to anyone, but you've got increasing complexity within care pathways, you've got the backlog, processes are becoming increasingly more disjointed. Again, you know, when you have 30 patients waiting in an A&E corridor, how can you then think about net zero and get your head around that? So there's definitely a capacity issue there. And some of that is compounded by, you know, lack of information and education. And again, clinicians are busy. And when you're looking at models of care work, often you have to have very heavy clinical input. So how do you carve out time for clinicians to be educated or understand those facets to be able to contribute meaningfully to the transformation work that's being planned? So it's not an easy problem to solve, but I think it can be solved, and hopefully I'll go through a few approaches as to, you know, and some take-home pointers on how you might be able to achieve this. I think for me, one of the key premises is to ensure that patient care is maintained or ideally even improved whilst driving sustainability. And often, and again, I'll highlight with some case studies, those things are not mutually exclusive. So having a more sustainable, both in terms of environmental sustainable pathway, actually will have financial benefits, may improve patient outcomes and convenience and everything else. So they're absolutely not mutually exclusive, and we need to make sure that we promote that as a view. So for me, I think again, as orthopaedics, we like to categorise things into three areas. So as a bit of a take-home, measure, promote and enable. I think that is a lot of the principles behind which we build upon our models of care practices. And again, I'll sort of discuss that in a bit more detail. In terms of case studies, so a couple of very close to my heart in terms of trauma and elective surgery, and then we'll touch on a quick one about oncology as well. And again, these are just to highlight examples of use cases. There's, you know, hundreds more, but ones that I know particularly well. So starting with trauma. So trauma is already network-based. Major trauma networks are very well known. Interestingly, other nations like the Republic of Ireland are setting those up now and following the UK model. But what a network-based model sort of alludes to is you have to try and think systems-based, not just your individual kind of locality. And how can you have benefits across that entire network, not just in one particular facet of it? So this is the trauma pathway. You can see there's a huge number of steps. There's sometimes back and forth within these, and it's how do you optimize this effectively? So breaking it down again to look a little bit around pre-hospital care. And again, there's lots of different technologies out there that are available. So systems integration is particularly key. I know, the ambulance trusts are making fantastic strides in terms of access in the field to things like GP records. And NHS Digital have the National Records Locator. So trying to essentially give people in pre-hospital the right information about that patient so that they can be taken to the appropriate facility. So you don't get that wastage where someone goes into their local A&E and then finds they have to should be better off somewhere else 5-10 miles down the road. Now, we do that in major trauma to some extent because it's very obvious. So anyone with a major traumatic injury will bypass the local hospital and go straight to the major trauma centre. But can we do that with other use cases? So you end up going to the most appropriate facility straight off the bat rather than just going to the closest. So again, having some of that systems integration, particularly at national level, will hopefully unlock quite a lot of that. And again, it's something to think about if you're trying to design a new model of care, about how you incorporate that in the pre-hospital setting. And similarly, sort of standardization in terms of guided protocols, guided treatment, again, trying to minimize unwanted or unwarranted variation. And then, as I mentioned, getting people to the most appropriate location at the first attempt. So once someone is at a facility, what do you do next? So this is around cross-organizational collaboration, particularly with the integrated care systems. Clearly this lends itself very well. Appreciate different parts of the country are at different levels of maturity in terms of sort of collaborative working. Most of this is fairly standard. People understand things like remote care pathways and telemedicine, but have a think about escalation. So how do you appropriately escalate patients? So they may be in a community facility, they don't need to come to the high acuity centre, but actually you do need a bit of advice. So do you need to set up an MDT to allow that to happen? How can you do that asynchronously? Because again, synchronous MDTs are very resource intensive, and trying to get a lot of clinicians together at the same time can be challenging. And then there's some, I guess, more back office or the foundational issues to think about, which are often forgotten. Things like medical legal. So when does the clinical responsibility of that patient transfer? So are they at the local hospital? Are they going to be at the specialist centre? Are you sort of looking after them on their behalf? For example, the neurosurgery, quite a lot of the time the neurosurgery services are centralised, and they provide advice to the local centre who may not have any neurosurgical service. So with that, then at what point is the responsibility the trauma teams versus the neurosurgical teams, et cetera, et cetera. So there's a few things to think about in those areas. And again, I think technology can be an enabler to this. And again, back to that sort of measure, promote, enable mantra. By improving the governance of the communication that happens, you can set much clearer boundaries about when things like care responsibility is transferred. So when communications are more ad hoc and advice is given, then it becomes much harder to have that sort of clarity. And then around the measurement aspects, network visibility and network planning. Again, numbers and data are very helpful. That will help you allow to plan resources and continue to improve your model once you've set it up. Similarly then on the rehab and prevention, again, this bit traditionally the NHS has not done very well, so it's something that we really want to try and enable to happen going forward. Again, the ICSs feed in very well to this, but the secret is how do you actually make it happen for real? And that is a real challenge. Again, technology can help with centralised services, good communication. Again, a lot of that is a given. But there is some things around secondary prevention. And back to that issue I talked about, clinicians are very stretched. They don't have necessarily the capacity to think, let's set up a preventative service. So again, technology can identify high-risk patients, and you can automate some aspects of prevention. So you can say this cohort of patients came in with a fracture, they need to be referred to a fragility service so they can be put on bone protection if they're not already. So again, that's just one particular example, and there'll be lots more, but it's about how can you make sure you build in that recovery, rehab and prevention space into your model, because as I said, often people think problem solved and then patients left to follow up with their GP, which I think nowadays we recognise GPs are also highly pressured, so that's also going to be a challenge. This is the virtual fracture clinic example, and again, I won't labour this in terms of too much detail, but traditionally this is a very face-to-face model. You know, patient broken bone comes into a fracture clinic, has a cast, etc., etc. And taking a whole systems view on this, you can really make some big changes and to drive sustainability. So that might be not using cast as often. So a lot of patients we know now can actually be put on removable splints. There was actually a fantastic randomized controlled trial done on a lot of pediatric buccal fractures, so a relatively minor pediatric fracture, that said they didn't even need a splint, so they needed a bandage, and that's, you know, level 1 evidence, randomized controlled trial. So building that in now to the referrer. So if someone's in A&E is seeing a patient with a pediatric patient with a broken wrist, referring a patient, they can have that information surfaced. Have you read the FORCE study? Do you know that patients do not necessarily need a splint? So suddenly you've gone from what used to be a cast and 3 follow-up visits down to a bandage and a digital information sheet, and the patient doesn't need to come back. So you've saved a huge amount of activity already with such a very, you know, such a simple intervention. And there's, as I said, there's countless examples of that. And it's why clinical input is really important, because really your clinicians will be the ones to tell you that and drive that. As I said, I know it for orthopaedics, which is why you're going to hear a lot about orthopaedic examples, but there'll be lots of others. So again, you know, in reality, so this is from a single trust in the southeast. So they saved 119,000 kilograms of CO2 equivalent, so driving to the moon and back, with 13,000 patient visits saved. So you can see, you know, massive volumes of savings just through a simple triage, information, guidance type pathway, all enabled by technology. And obviously, you know, patient travel, convenience, et cetera, et cetera. So the benefits are huge. And it's really just taking that systems approach, looking through the whole pathway, start to finish, and coming up with a solution to deliver on that. So these are the sort of main key areas, I guess, about where you can have benefits. So the operational energy consumption, again, there's lots of different frameworks and models, so find which works for you. This tends to work quite well for me. So reduce patient travel, unnecessary in-person patient visits, and again, I think there's a huge amount there that can be done, and that is not just telemedicine. It's not just this is a phone call or a video, as I mentioned. It's actually changing the treatments that you provide, a bit like the example I gave earlier. And then fundamentally, you cannot have a universal sort of virtual solution. You do need to see patients face to face. And the key is then identifying those patients early, prioritizing those resources for that group so that you can get them through a bit faster. So again, I'm going to talk about elective surgery, where that last point is probably the most relevant and pertinent to it. So you can see here, this is your typical kind of surgical journey in very sort of high level strokes, but you can see that there's carbon impacts at all aspects, from the original patient being listed for surgery to their preoperative assessment, and then all the way through to the end. So we were working on ways to try and capture that automated, so actually trying to capture carbon impact in real time. For example, what the modelled impact of giving certain types of anaesthesia might be as well. But where it becomes really interesting, and I think this is particularly elective surgery with a huge backlog and obviously substantial patient volumes, how can you keep those resources ring-fenced or earmarked for those patients that actually do need it? So you're not putting everyone through the same pathway. You're actually cohorting and segregating patients. So you can do this very simply. So again, some of that systems integration, if you can access patients' GP records as part of their preoperative assessment process, and again, there's no reason why you can't. The NHS Digital have fantastic infrastructure now. I think programs like GP Connect. You can get information directly from patients through questionnaires. Again, trying to identify those that are low risk. So again, in orthopaedics, this would be your 25-year-old with an ACL injury. Do they really need a pre-assessment, or meniscal tear? They can just come in on the day, have their day surgery, and go home. And then similarly, you can identify those patients that are very high risk. So this could be your 85-year-old, multiple comorbidities, cardiac disease, diabetes, etc., needs a revision hip replacement, something like that. So you then want to put that patient through a appropriate preoperative assessment process, go through their entire sort of history, any additional testing. And again, you can think about different models for that. So one-stop clinic, so where you have CPEX or cardiopulmonary exercise testing, as well as the blood test and everything else all in one visit. So by identifying early that this patient is high risk, you get them through an early assessment process. You might pick up things like their diabetes is not well controlled, and then again optimize that during their waiting time. So actually by the time they come to surgery, they have been fully optimized, and you haven't spent your sort of team's time on the low risk patients that actually it was just a quick hello, and you're wasting, you spend even 15-20 minutes with every patient just ticking a few boxes. So I think that's where having that stratification really helps. So in-person care is absolutely a must, but you can save it for those that it will yield the most value for. So again, thinking about sort of domains of how you can structure that. So improving care coordination, so workflow, having very streamlined workflows, again, allowing for things like escalation. So your preoperative assessment team can escalate to your anaesthetist without then dragging the patient all the way back. So they've got all the information, it sort of passes through, or running one-stop models as well. And clearly, some of these benefits can be particularly helpful when you have a very distributed community. So things like the ICSs and centralized surgical hubs will certainly mean that patient travel is going to become much greater. So again, often the places with poorer access are the ones that have the worst sort of health inequalities. I'm thinking particularly around coastal communities. They're often quite deprived. They often have large geographies to travel, and therefore their care suffers. Which is what I'm probably going to touch on my final sort of example around oncology. So this is a model looking at community-based diagnostics in skin cancer. Again, we found that the workforce, particularly in dermatology, is highly pressured. There's 600 and something dermatologists in the country, huge volumes coming through. So how do you manage that population? And teledermatology with, as I said, HCA or nurse-led imaging in the community with a detailed patient history can absolutely help. So this is one particular area. Why it's not projecting quite as clearly, but it is sort of on the southeast coast. So you can see there's only one dermatology hospital in that entire region. You have patients travelling for up to 2 hours for what is a 5-minute mole check. So you can see that is not a particularly great way to run a service. And unfortunately, you can understand from the provider perspective that it's the only option because you only have 3 dermatologists. So because again, often these areas struggle to attract staff to work there. So the dermatologist service by definition has to be centralized to allow at least some activity to occur, but that negatively impacts the patients massively. So by moving some of that diagnostic capability, again with technology such as dermoscopy, information transfer using cloud solutions, that really then enables those patients to have a local service but have that expertise, access to that expertise that is central. And then absolutely if they end up needing a biopsy or further diagnostic investigations, they again attend in a one-stop type model. So they only have to go once, it's all dealt with, and again everything else follow-up can be remote. So and what we often find is these sort of areas with poor access are the ones that have the poorer outcomes. So again, trying to address all of those. And you can see I haven't really talked about net zero in any shape, way or form, but all of this, you can understand how it has massive downstream benefits just by running a model that is actually more convenient for patients, more convenient for clinicians, has better outcomes, is arguably more financially cost efficient, and then you will have those downstream benefits. Right, so how do you make this a reality? So as I mentioned, kind of key take-homes for me were around measure, promote, and enable. I think it's very difficult if you don't know where you're starting from or what your starting point is. So having some baseline measurement capabilities, try and automate this as much as you can. It can be difficult, but there are some resources out there. So NHSD so we work with them quite closely. They're obviously doing a lot of good work around their dashboards, and they're improving all the time. They've also got the models of care work stream, which again, if anyone's particularly interested in this sort of area, it's worth touching base with them. Look at your procurement data, look at technology or digital solutions that can help at least capture some of that and automate it. And then there's also a lot of health sector-led groups. Again, I think Pete, who's in the audience, has done some fantastic work on a lot of this as well about collating data and resources. So definitely worth having a chat with him. So promote. Now, the workforce, although it is pressured, I think does really believe in sustainability. I think if you speak to most clinicians, they do want to make it happen. They just often don't know where to start or, as I said, just pressured elsewhere. I found the SUSQI framework to be very helpful, so I'd encourage everyone to have a look at that, which was created by the Centre of Sustainable Healthcare. And you can see their domains are very linked to what I was talking about earlier in terms of prevention. So clearly not having to do something in the first place is probably the most sustainable option. So think about how you can build that in. Patient self-care, again, patient activation. Can they guide their own rehabilitation? Can they guide their own recovery to any extent? Lean service delivery. So a lot of that was what I talked about in terms of virtualized pathways, improving access with community-based services, and then low carbon alternatives. So that is now becoming more to the fore. Obviously, in terms of devices and equipment, the suppliers and industry are driving some of that. And again, that's where they have a key role to play. But again, some of that could be low carbon alternative treatment. So the example I gave about the splint and the bandage, that is exactly that type of thing that we need to think about. Similarly, anaesthetics have obviously done a fantastic amount of work in removing desflurane, but again, there may be other areas of improvement that are still untapped. So think about it at a systems-based level, because, as I mentioned, now models of care are becoming more complex. They do go end-to-end. They traverse multiple sectors and areas. So thinking of it in isolation, you're often going to run into problems. So do take an end-to-end approach if you are thinking about models of care and use some of the systems thinking methodologies. And finally, with enablement. So again, don't go out there. You don't need to go out there alone. There is help and support there, both locally, regionally, and nationally, industry and third sector. So again, I've just pointed out some fantastic work being done by the Royal Colleges in terms of the Green Theatre Checklist and the Green ED framework. So there's a lot of interest. There's a lot of appetite in this. So again, for me, this is collaborative between everyone. So do engage and see if you can get people to help you along your journey. And then the final bit's really, again, just to hammer in, measure your impact, promote sustainable decision-making by design, use technology as an enabler, and then finally kind of, go for it. So implement and promote those sustainable practices and talk about them and share your knowledge, share your learnings, and hopefully get people to follow you on your journey. So just as a final sort of call to action, how do you plan to cultivate your own sustainable model of care going forward?
Thank you very much, Piyush. That's absolutely incredible. Not only have you found a solution that literally answers all of the triple bottom line, you've also completely broken the stereotypes about orthopaedic surgeons. So.